Okay, next up for us is blood. This will complete the cardiovascular system, which is the heart, blood vessels, and blood. Always going to jump over here, at least touch on this, because I do want to keep repeating that there are different levels of knowledge. They were characterized by a guy named Benjamin Bloom. Also, I want you to keep in mind that there are major skills, or I call them big ideas, that everything in A&P keeps coming back to. Be a good critical thinker, make complex things simple, and that for a deeper understanding, relate anatomy to physiology, to clinical care, pharmacology, clinical testing, and disease. Our main areas are going to be physical characteristics, functions of blood, composition of blood, and hemostasis, which is to keep the blood in the vessels. This is kind of a nice picture because it shows the three major constituents of blood: red blood cells, white blood cells, looks like a T cell, and platelets. This is more or less a joke to make sure you're not queasy at the sight of blood if you're going into healthcare. My daughter is very queasy at the sight of blood. She won't be a nurse. As is my usual way, I like to make infographics. I think the Prezi itself is more or less an organizational infographic because you start with the foundational knowledge in the beginning or towards the middle, and then you radiate out. But I want to keep using these because you can get a lot of information on a tabloid sheet of paper. On this sheet, we have the major functions. We have the constituents of blood, so plasma, types of cells. We have hemoglobin in here. We have hemostasis, and then we also have blood typing. So we'll start with physical characteristics. Blood is sticky, opaque, tastes a little metallic because of the iron. One of the biggest misconceptions out there is that blood is blue. Blood is only blue if you're a horseshoe crab. When it's loaded with oxygen, blood is bright red. When it's low in oxygen, it's dark red. If someone looks very, very red, they may have carbon monoxide bound to their hemoglobin because carbon monoxide binds very, very well to hemoglobin. pH is usually slightly basic to be ready to balance out acid. The temperature is a bit warmer due to the friction of flowing. About 8% of your body weight is your blood. We sort of mentioned this before, that you want to be able to move blood around rather than fill all your vessels at once because blood is heavy. Lastly, we also mentioned before that the average male has 5 to 6 liters of blood, while the average female has 4 to 5 liters of blood. Here's the typical cue that DJ is going to talk about perspective and looking at A&P from the right direction. I think the main right direction, again, is to relate anatomy to physiology to disease. It's the why of why you're doing what you're doing, because it relates to your own health and it relates to the health, the future health of probably your patients. Or if you're in the healthcare field, you're always going to have an aunt asking you about this different thing or that different thing. So it's good to know the different pathologies. The major diseases of the blood are the anemias, where the blood isn't carrying enough oxygen. We'll talk about those shortly. Hemoglobinopathies, where the hemoglobin is changed by mutation. Hematological malignancies are cancers like leukemia. Coagulopathies are problems with clotting like hemophilia, or disseminated intravascular coagulation, where you get clotting where you shouldn't. The last thing is infections of the blood, so like sepsis. Of course, there's even more detail, and you can explore simply by getting on Wikipedia. Again, I would say that you might want to do your future self a favor by matching anatomy to physiology to pathology now if you're going into allied health, or if you know you have a condition or someone in your family has a condition that might impact your later life. Looking at that chalk drawing from the right direction, so here it was before, and now we're looking at it from the right direction, the right perspective. Looking at blood from the right direction, the stars represent different pathologies, with the point being that we're studying anatomy and physiology because it might relate to your future patients you care for. I guess I kind of already said that. Or even conditions that may strike people in your family or you. We're going to do blood typing, which is on our infographic here. Blood types come from the proteins on the outside of red blood cells. They're called antigens that might activate the immune system. There are over 30 of these proteins. Originally, the proteins were lettered A, B, C, D, etc., so on and so on. After identifying the proteins, it turned out that really only A, B, and D generate a potent enough immune reaction to need to be accounted for when transfusing blood. D is also known as Rh from rhesus monkey and is indicated in a blood type by a positive or a negative. So an A positive blood type has the D antigen, or an A negative does not have the D antigen. The other type of blood, O, is when neither A or B antigens are present. I looked for a long time for a chart that showed the blood types, antigens present, antibodies, pictures of blood smears, as well as those who could receive blood from whom, who can donate blood to, who can donate plasma to, or who can receive plasma from. I'm not going to go through this chart in a great detail because it's going to come up as a link in a YouTube video, and I would just refer you over to that video. We learned when we talked about antibodies that sometimes they will clump together large things. This was called agglutination. If an antibody finds foreign blood, it agglutinates it, it clumps it up. This means it begins to form clots, and those are going to block blood vessels. So that's why we care about ABO blood groups. Check yourself a little bit here. So here's what an unclumped sample looks like: clumping, non-clumping, and clumping. So the way to think about this is if the anti-A antibody found the A antigen, it's going to clump things. So if it clumps, it is that type. So this is A-type blood. B did not clump. D did clump. So that would make this A positive blood. Go ahead and quiz yourself on the rest, and then look down here for the answer. Blood group O is the universal donor because they can give blood to all of the groups. They don't have the A antigen, they don't have the B antigen. You can put them in somebody else's body, and that person won't have antibodies against it because there's no protein there. Oh, the reason this one's mean is because we're doing it this way. So here's the first patient, here's the second patient, here's the third patient, here's the fourth patient. No clumping, so that's O. So go ahead and cross out B, cross out D. Looks like both A and B are clumping here, so that looks like AB blood. So I like A at this point. Oh, but C is the same thing. A is not clumping, B is clumping, so this is B-type blood. So our third one is B, and then hopefully our last one is A. A is clumping, B is not clumping, so this is an A patient. So I think we went with A there. Nobel also has a little game to test yourself if you want to go to that site. Rh blood groups are a little bit different. For one, you don't automatically have antibodies against Rh if you're Rh negative. That's different than from AB blood. In AB blood, if you lack an antigen, you will have made an antibody because the antigens are also on the food you eat. So if you're an A-type, you will have anti-B antibodies in your blood. If you're a B-type, you will have anti-A antibodies. If you're O-type, you will have both anti-A and anti-B antibodies in your blood because you've been exposed to those antigens and generated those antibodies because of the antigens that are in our food. As a side note, it's one of those things that sometimes there's a little bit of truth. There is something called a blood type diet, which has just enough truth to make you think it's true, but I really don't think it's true, although I haven't really explored it a lot. Okay, so let's go into some conditions of blood typing. Okay, first, you'll have to recall a little bit about the immune lecture and that there are different types of antibodies. There's IgM, which are new antibodies, which are large, and IgG antibodies, which are small. So a difference between Rh and AB antibodies is that AB antibodies stay as the larger IgM. They don't break down to the smaller IgG antibodies. This means that these antibodies don't pass through the placenta. Rh antibodies, however, will break down to IgD, and they can pass the placenta. This leads to a condition called hemolytic disease of the newborn. So if a mother is Rh negative and the baby is Rh positive, the mother's immune system will attack the Rh positive blood if it finds it. Because blood does not pass through the placenta, so the blood cells don't pass through the placenta, the mother's immune system won't see the Rh positive blood and make antibodies during the actual pregnancy. However, during delivery, some of the baby's blood may enter the mother's blood. The mother's immune system will develop antibodies against the Rh blood, and on a second pregnancy, the Rh antibodies are still in the mother and may pass through the placenta and attack the second child's blood. That blood will then agglutinate. This figure shows how the blood cells do not cross the placenta, but antibodies do. So these blood cells are stuck and they will not pass through the placenta up here, until there's a rupture during birth. Also remember that since antibodies against A and B are larger, these antibodies don't pass through the placenta. So AB antibodies would still be stuck back here, whereas Rh antibodies can pass through. So we generally get hemolytic disease of the newborn due to Rh antigens, but not due to differences between the mother and child with respect to A and B blood types. The solution is to cover over that antigen on the baby's blood with an antibody that won't activate the immune system. This is why a mother is given RhoGAM periodically during a pregnancy and after delivery. RhoGAM is an antibody itself that will find the Rh antigens in the fetal blood that makes it into the mother and covers them up. This hides the fetal blood from the mother's immune system. Any female that's Rh negative will probably need to get a RhoGAM. Technically, if the father is Rh negative, this would not be necessary, but rather than having the discussion of, are you sure it's his? RhoGAM is usually given. There are generally two types of transfusion reactions. If you give the wrong type of blood to a person, their immune system may attack the blood. Another type of transfusion error can happen if you transfuse plasma. There are antibodies in the plasma that may attack the blood in the person receiving the plasma. So if B-type plasma with anti-A antibodies in it is given to a person with A-type blood, the antibodies can cause some agglutination. Most transfusions are packed red blood cells to avoid this. Here's some more specifics. If red blood cells from a person with type A blood is given to a B or O blood recipient, the recipient's immune system will attack the blood and agglutinate it. Also, if the plasma from a type A person, which will have anti-B antibodies in it, is given to a person with B-type blood, the antibodies might attack the blood. Clearly, this is a much bigger problem than this because there's a whole lot of antibodies that can attack a whole lot of blood cells and cause a whole lot of agglutination. In this case, there are antibodies in here that can agglutinate this blood, but there's not a whole lot of antibodies in there. Mastery thinking. I don't have a lot of things here, but you might investigate hemolytic disease of the newborn a little bit more, or investigate more of the history of blood typing and things like that. Let's now look at functions of blood. I'm sort of a visual person, so I like to come up with a picture that helps me remember things. The three main functions of blood are to distribute, which makes me think of highways, to regulate, which reminds me of OSHA, and to protect, which reminds me of the military or the police. So we can break these up a bit more and note that distribution involves delivering oxygen, nutrients, picking up metabolic waste, and delivering hormones. Things that the blood needs to regulate are body temperature by moving the blood out to the skin to get rid of heat or to the core to retain heat. The blood carries things like bicarbonate to regulate pH. Lastly, there are things in the blood that ensures that the fluid volume is maintained, like clotting to prevent blood loss. So maintain adequate fluid volume. Blood also protects, sort of similar to what we just talked about. Blood prevents blood loss by platelets or clot formation. We'll talk about that at the end. Blood also has things in there to prevent infection, things like antibodies, complement, white blood cells. Which of the following is a function of the erythrocytes? It's not going to phagocytize bacteria, not going to mount an immune response, not going to kill parasitic worms, not going to release histamine, transport oxygen and carbon dioxide. Kind of an easy one. It's a fair question on the test to ask if you have the different functions of the blood divided up by regulation, distribution, and protection. So maintaining normal body temperature, that's a regulation. Delivering oxygen, that's a distribution. Transporting hormones, that's a distribution. Maintaining normal pH, that's a regulation. Preventing infection, that's the protective one. On this slide, I just wanted to put everything in one slide for a review. So those are the functions. Mastery thinking, I think one of the key things to look into, or just even think about, is look into attempts to create blood substitutes. And consider why this is such a daunting problem. There's so much that's in their blood, and you have to have a hemoglobin. We'll learn more about this in the respiratory system, that picks up oxygen well in the lungs and then delivers it well into the tissue. When I was a grad student in Iowa 20 years ago, a blood substitute had been recently invented. And I remember how all the buzz was about how wealthy the inventor was going to be and how this would propel the funding of the school. Sorry, that's grad school. But then again, it was also like, what could this do to the future of health if you could actually have a blood substitute? Because then you wouldn't have to give transfusions. You wouldn't have to have transfusion errors. You wouldn't have to risk giving disease through transfusions. It would change things quite a bit. Composition. So we can see on our concept map that this is where most of the content is. We're going to ask about plasma, white blood cells, red blood cells. So we're asking the question, what are the parts of blood? First, it's interesting that blood is still a tissue, meaning it's a group of cells working together towards the same function. It's just that all those cells are in a fluid rather than putting together the parts of an organ. The two main parts of blood are plasma and the formed elements. The formed elements are red blood cells, white blood cells, and platelets. I like to keep communication simple, so I will usually refer to red blood cells as RBCs, white blood cells as WBCs, and platelets. But you should recognize the technical name for a red blood cell, or RBC, is an erythrocyte. And the technical name for a white blood cell, or WBC, is a leukocyte. Knowing the technical terms will help you remember things like what erythropoietin is, so it has the erythro in the name, or what an interleukin, because it's between a leukocyte. We'll get to those in a little bit. We can separate out the parts of the blood pretty easily by centrifuging it. When blood's separated, the percentage of the whole blood that is the red blood cells is called the hematocrit. In my constant effort to relate anatomy to physiology to clinical testing, I'm going to recommend that you go and look up what things hematocrit can be used to diagnose. Just do a Wikipedia search of hematocrit. You can see the various conditions that are indicated by high hematocrit, which is too much blood or too little fluid. Think about that. High hematocrit is either too much blood or not enough fluid. Blood doping would cause too many red blood cells, or dehydration would cause too little fluid. Or maybe you have a lung disorder and then you have to have more red blood cells. That would also cause an increase in the amount of red blood cells. A low hematocrit would indicate too much fluid, maybe from retaining water in pregnancy, or too little blood when something is killing RBCs, or not enough blood cells are being made in anemia or leukemia. This is just a start. It's just an interesting look at some of the other conditions and think, yeah, that kind of makes sense. Honestly, a normal hematocrit is about 45%. Just eyeballing it, this one looks a little high, but on a previous slide, the normal hematocrit is 45%. If I jump back here. This is a nice figure from OpenStax and Wikipedia that just shows the formed elements and the mature white blood cells that you're going to want to know. Clearly, there's a lot of information here. What I would focus on is the types of cells in this column here, and then the summary of the functions. I'd probably even distill it more like neutrophils kill bacteria, eosinophils fight parasites and cause inflammation and allergies. Lymphocytes are part of the third line of defense, and since most bacteria are eliminated by the first and second line of defense, lymphocytes mainly kill viruses. And monocytes are generally scavengers, engulfing debris and pathogens. We're going to repeat that again soon, but as I always say, redundancy is good in AP2. Get it in there good. Now let's look closer at the components of blood, beginning with the plasma. So plasma is 92% water, but there are some other things in there. There's several things dissolved in plasma. You don't need to memorize them specifically, but maybe have an appreciation of them. For example, we talked about albumin when we talked about osmotic pressure in capillaries. We'll talk about albumin again in relation to its effects on calcium and acid when we get to the urinary system. And I don't know if I've mentioned it yet, but the urinary system is the most difficult system in AP2. Globulins are things like IgM, that stood for immunoglobulin. Of course, there's electrolytes in the blood, with the three main ones being sodium, potassium, and calcium. Sodium, potassium, calcium, sodium, potassium, calcium. One more time. Sodium, potassium, calcium. Of course, honestly, there's not that much oxygen in the plasma, maybe 2%. Moving on from plasma, we'll now look at the formed elements more specifically. So this figure again is nice because it reviews the formed elements. The formed elements are red blood cells, white blood cells, and platelets. It's interesting to note that red blood cells are incomplete. They're so efficient at being made that they kick out their nucleus, and then that also makes them more full of hemoglobin and able to squeeze through capillaries better. That's also why they only last about 120 days, because they don't really have the repair mechanisms. I mean, they do have things like constituents of the cell a little bit, but not a whole lot. Things like RER and stuff like that. White blood cells are complete cells. Platelets are just parts of cells, fragments. Red blood cells. By far, most of the formed elements are erythrocytes, so 99.9%. Recall that when you look at a blood smear through a microscope, there are a whole bunch of red blood cells, way more than white blood cells. The white blood cells being the little purple ones. Red blood cells are biconcave, so they have two dishes in them, sort of flat with a middle thinner than the perimeter. A cool thing about red blood cells is they're almost completely full of hemoglobin. They're stuffed full of hemoglobin. I think it's even cooler that they don't use oxygen to make ATP, because all the oxygen in there is for delivery. So red blood cells have a nucleus when they're being made, as they kind of needed the DNA to direct protein production. But as a last step, the nucleus is ejected, and it's actually reused. This means that the red blood cell is mainly just a bag of hemoglobin. Ejecting the nucleus makes the cell smaller, more flexible, and able to squeeze through capillaries in a single file row. Getting even more specific, the shape allows the most surface to volume. Since the cell wants to release oxygen and pick up CO2, the cell wants a large surface to volume ratio. Essentially, you don't want hemoglobin in the middle of the cell where it can't get out to exchange gases. I guess I already said this, but most of the RBC is hemoglobin, and the cell doesn't even use the oxygen it's carrying. We've mentioned this a few times, but let's get more specific about hemoglobin. Hemoglobin is the molecule that carries oxygen and carbon dioxide. We're going to learn about it a whole lot more in the respiratory system, but hemoglobin is made of 4 globin proteins. Recall that hemoglobin is the classic example we used early on in AP1 about structure of proteins, specifically quaternary structure in proteins. where proteins are made separately and then joined together. Can you remember primary, secondary, and tertiary? Primary is the amino acid sequence. Secondary is folding into an alpha helix, which is kind of like having a 2x4 or spiral staircase, I suppose, kind of, or a beta sheet, which is kind of plywood. So I always think about how you can build a lot of things out of 2x4s and plywood. So that's why you can build a lot of different proteins out of alpha helix and beta sheet. You do have a little bit of random coil in there too, which is unstructured. Then the combination of alpha helix and beta sheet is tertiary structure. The reason to know these terms is that there's things like sickle cell anemia is caused by a mutation in the primary structure of the beta chain. So from Wikipedia, I got to come up with a Wikipedia voice. The gene defect is a known mutation of a single nucleotide, A2T, of the globin gene, which results in a glutamic acid being substituted for valine at position 6. That's kind of striking, honestly, about proteins. One amino acid out of probably thousands has been switched, and now this protein doesn't work the way it normally should. Thalassemia is another type of hemoglobin disorder that can affect both beta and alpha chains. In the middle of each globin protein is a heme molecule. So let's get this out of the way. Talk about that. So we can see that heme better here. At the middle of the heme is an iron. This iron is why we so often associate problems with red blood cells with a deficiency in iron. But do note, and we'll cover this, that anemia simply means a loss of oxygen carrying capacity or a decrease in oxygen carrying capacity. This can be related to iron, but there are multiple other causes of anemia that we will get to shortly. Which is false. If hemoglobin was free in the plasma rather than being contained in the erythrocyte, boy, you kind of need it in that cell so that you can kind of move it around at will. It would probably leak out of the bloodstream. I don't think hemoglobin would be more stable if it wasn't in the protection of the red blood cell. Viscosity of blood would increase. I think that's probably true. Osmotic pressure of blood would increase. Well, if you had a whole bunch more protein in addition to the albumin, the osmotic pressure would definitely increase. So what we were doing here is always remember to look for the false. I do think hemoglobin would leak out of the bloodstream. I do think the viscosity of the blood would increase because you got a lot more things to bang into the wall of the vessel, a lot more things in the blood. Osmotic pressure, which is normally created by the protein albumin, would go up if you added a whole nother protein into the blood. So that's why we have this hemoglobin in red blood cells. Hemoglobin has different names based on what's bound to it. So if oxygen is bound to hemoglobin, what I'm trying to show here, it's called oxyhemoglobin. If no oxygen is bound, it's called deoxyhemoglobin. If carbon dioxide is bound, it's called carbaminohemoglobin. That one's fun to say, carbaminohemoglobin. We'll talk about this a lot more when we get to the respiratory system, carbaminohemoglobin. I don't know if I mentioned it before, but the urinary system is the most difficult system in AP2. The process of making blood cells is called hematopoiesis. Hematopoiesis. This happens in the red bone marrow that's distributed throughout the body, also in the sternum, vertebrae, pelvic girdle, ends of long bones, and ribs. There's a really nice slide coming up here. Oh, I should have mentioned that the main cell, the cell that gives rise to blood cells, is called a hemocytoblast. Cool figure from Wikipedia shows prenatal, postnatal, what bones are actually making blood. Here's what's really depressing for all us old people, is look at this. It goes down no matter what. It never goes up. But someone my age, it's pretty much in the vertebrae and the pelvis at this point, and a little bit of blood formation in the sternum. I think most people would associate or think it's in the femur, but it kind of dies out of the femur around 27. The amount of red blood cells in the body, pretty important. If you have too few blood cells, you can't carry enough oxygen, so you get anemia. And from our discussion of the heart, you don't want too many blood cells because this would increase peripheral resistance. Blood cells would hit the wall of the vessel more often. That would increase blood pressure. That's going to increase afterload. That's going to decrease stroke volume, decrease cardiac output. The hormone that stimulates blood cell formation is erythropoietin, or EPO. Wonder why I have a cyclist there, because cyclists are pretty notorious, or had been pretty notorious, about injecting EPO. The interesting thing is they can go in and figure out that the EPO was distilled from a plant, was extracted from a plant, or from a person. So that's how they catch a lot of cyclists, or used to. EPO is released primarily by the kidneys. There's those kidneys again. You wouldn't think that the kidneys are the organ that sends oxygen, but about 25% of your blood is going through your kidneys right now, so they see a lot of blood. So it's their job to keep an eye out on blood. So when the kidneys sense there's not enough oxygen carrying capacity in the blood, they're going to release EPO. Low oxygen carrying capacity can usually arise from these conditions: too few red blood cells, not enough oxygen to pick up, or increased need for oxygen. Now from there it gets a little bit more complex. I've overlaid some causes of these conditions, but you might want to think about things even more or look things up. So too few blood cells can be caused by loss of blood cells due to hemorrhage, destruction, or the inability to make blood cells. You can get reduced oxygen if you live in an oxygen-poor environment, as an altitude, or if the lungs are having difficulty getting in oxygen, like in COPD, emphysema, lung cancer, things like that. If you increase asthma, if you increase your exercise schedule, you will increase your need for oxygen as well. So all of those things would result in a low oxygen carrying capacity. The kidneys would release EPO. The liver does a little bit if you lose your kidneys. That's going to tell the bone marrow to make more blood cells. That's going to increase your red blood cell count in circulating blood and increase oxygen carrying ability in the blood. Which statement is not a factor in stimulating the production of erythropoietin by the kidneys? I need like a game show voice for these questions. Need a Wikipedia voice, need a game show question. Which statement is not a factor in stimulating the production of erythropoietin by the kidneys? Excessive destruction of the red blood cells. I like that one. Living by the seacoast. Know that there's plenty of oxygen at the seacoast. Living at a high altitude where there's not enough oxygen. That's a good one. Excessive bleeding where you're losing red blood cells so you can't carry as much oxygen. And inflammation of lung tissue, as in pneumonia, you can't pick up as much oxygen because there's fluid in the lungs. Yeah, kind of got to lose that voice. But it was fun for a while. Which group would you expect to have a higher hematocrit allied? Smokers, a slacker A&P instructor, an individual with pernicious anemia, or normal individuals? You would expect a higher hematocrit in somebody that's having difficulty delivering oxygen. So I would say that's smokers. We have mentioned these details before when we talked about the spleen while covering the lymphatic system. So red blood cells live about 120 days. As they age, red blood cells get more rigid. The capillaries in the spleen are stiffer, so when the older red blood cells go through the spleen, they get crushed or they get lysed. The iron is recycled while the rest of the protein enters the digestive system to reclaim amino acids. How cool is that, that you digest your wasted proteins and put those amino acids back into other proteins? Other breakdown products like bilirubin will go to the liver. Other parts of the heme molecule are processed, also beginning in the liver. It's a nice picture that takes you through the life cycle of a red blood cell. As I mentioned before, you might take note of bilirubin over here, because when you break down blood, you get bilirubin. So bilirubin is a good signal that something is killing blood cells. Now bilirubin itself, we'll get to this, but I gotta say it because the urinary system is the most difficult system in AP2. So let's get this into your brain a little bit. The liver will convert it to something else called urobilinogen, but then if you see lots of urobilinogen in your urine, it means something's killing red blood cells. So it's a little more complex than what's on this figure, but that's kind of a good start. I want to say it. I'm not going to say it. Okay, the urinary system is the most difficult system in AP2. Renal dialysis patients usually suffer from anemia because this is true. The kidneys are making EPO. If they're damaged, they're going to stop releasing that. And so I like A. I don't know. I mean, you could argue, you can make an argument that if the kidneys are not getting rid of toxins, that might shorten the lifespan of red blood cells. There are cases here, too, where essentially the kidney kind of gets bound up with antibodies, and then that destroys capillaries, and that might damage red blood cells. That's true. But I think the better answer, we'll call this an NCLEX question, where all the answers are correct, but you got to find the better correct answer. And the better correct answer is A. I mentioned it briefly before, but if you do have kidney issues, the liver does make enough EPO often to sustain life, but it's not going to be a comfortable, full of oxygen life. Polycythemia is a condition where there are too many red blood cells. The three main causes are polycythemia vera, where there's just too many cells made by the bone marrow, and this would generally indicate a malignancy. Secondary polycythemia, so poly means many. Secondary polycythemia, where the body has upregulated red blood cell production due to a lack of oxygen. So this could be due to intense athletic training, living at high altitude, or having problems with the lungs. That's an example. There's more. Blood doping, specifically injecting erythropoietin, is an additional cause of polycythemia. All right, anemia. While we often think about anemia, kind of already said this, as being a low iron situation, the actual definition of anemia is the lack of oxygen carrying capacity, or the loss of oxygen carrying capacity. Low oxygen carrying capacity. Also, anemia is a symptom rather than a disease, sort of like you wouldn't call hypoxia a disease, or you wouldn't call cyanosis a disease. These are symptoms, not really diseases. The three main causes of anemia are not enough red blood cells and then insufficient hemoglobin, which might be not enough or there's something wrong with that hemoglobin. You can find the anemias mapped on the other side of your blood concept map. Polycythemia is up here too. So on the top left are disorders of decreased red blood cells. Another cause is decreased hemoglobin content, which are shown here. And abnormal hemoglobin is also a cause of anemia. It honestly might just be easier to study it on this, but we'll go through those. Anemia is a disease that involves too little iron. Give me my money back because you just said it's not a disease. Okay, but it's that iron thing? No, it's not that iron thing. So while most cases are related to iron deficiency, anemia just means there's not enough oxygen carrying capacity. The three main things that can cause there to be too few blood cells: hemorrhagic anemia, where you've lost blood. Can't really show a picture, or maybe don't really want to show a picture, or already tried to make you queasy. Hemolytic anemia, where there's something, you can see the debris in here. There's something causing the blood cells to rupture. This would be a lot of things: toxins, virus, hypotonic solutions, sepsis, anything. Aplastic anemia, where there's a problem with the production of the red blood cells by the bone marrow, so you're not making enough blood cells. Two main things that can cause there to be too little hemoglobin. Iron deficiency, this is a classic, where there's inadequate iron to create the heme molecule that sits in the middle of the hemoglobin subunit. I would look at this one. This one's kind of interesting. This one's another one that's kind of curious because in order to absorb B12, your stomach has to work. So if somebody has a problem with their stomach, they can't absorb B12, and the next thing you know, they have pernicious anemia, where there's a deficiency of vitamin B12. Without B12, production of the amino acid methionine will be reduced. Maybe you recall from early in AP1 why methionine is important. It is because since the first amino acid in all proteins, so that AUG subunit codes for methionine, that start codon, a reduction in methionine will slow protein production. So one of the most made proteins is hemoglobin. So reduction in B12 will reduce protein production, which will reduce hemoglobin production. So again, the stomach actually, this is a sidebar note, but it's kind of interesting about how the different body systems are connected. That's one of our big ideas in the class, is when you eat or consume B12, the stomach can digest it. So it needs to be protected from digestion by something called intrinsic factor. Lack of intrinsic factor would cause digestion of the B12. You wouldn't have the B12, and so you go into pernicious anemia. So problems with the stomach can lead to pernicious anemia. And that's also often why B12 is given as an injection and not a pill. The two main causes of abnormal hemoglobin are thalassemia and sickle cell anemia. So in thalassemia, there are mutations in, I said that like a Canadian. In thalassemia, there are mutations in either the alpha or beta chain of hemoglobin. So thalassemia is more of a cluster of mutations. Sickle cell is pretty specific. We talked about that before. I believe it was the 5th amino acid where there's a single genetic mutation. I should have said that in my Wikipedia voice. Under low oxygen, the hemoglobin will polymerize, so to form these long strands. These strands are going to push against the wall of the red blood cell and actually change the shape of the cell. So I don't want to go into great detail about this, but I'm trying to pique your interest a bit. If you have a complete blood count and a white blood cell differential, if you've ever had one of those as a blood test, you'll see values for hematocrit, numbers of various white blood cells, number of platelets, concentration of hemoglobin. You're also going to see things like mean corpuscular volume, which is a measure of the size of the red blood cells. So certain types of anemia, like pernicious anemia, will allow cells to start division, but then they get stuck at cytokinesis. So they start mitosis, but they don't get all the way through it. So the red blood cell becomes twice the size of a normal cell. It can't complete the division, so it just pops into a cell that's twice the normal size. The inability to fill the red blood cell with hemoglobin will cause the cell to be smaller. So iron deficiency anemia or thalassemia will cause microcytic cells. Mean corpuscular hemoglobin is a measure of the color of red blood cells, and it indicates the amount of hemoglobin in the cells. Iron deficiency anemia is a classic example of a condition that causes hyperchromic cells. So you would have seen this in lab, where without enough iron, you don't make the hemoglobin and the cells look ghost-like. Hyperchromic cells are more rare, would indicate a malignancy, or the red blood cell is in an abnormal shape. So sickled cells can often look hyperchromic, or there's a condition called spherocytosis, where red blood cells can be really big and really small, and then the really small ones are packed with hemoglobin, so they look more red. So I'm going to keep kind of pushing at this. The humans are brilliant when it comes to clinical testing. Like, we're still idiots because we should probably do more clinical testing because it should be cheap. Like, we should do EKGs once a year. They're pretty cheap. We should do urinalysis every now and again because that's pretty cheap. But you can look at corpuscular volume and hemoglobin concentration, and that allows us to whittle away at what might be causing an anemia. So you're feeling really tired. You think it's anemia. You go to the doctor, and they do a complete blood count, white blood cell differential. So this would be more of a complete blood count. By looking at the color of your cells, the variability of your cells, and also the size of the cells, they can figure out that your anemia might be caused by aplastic anemia. You wouldn't want that. Blood loss, iron deficiency, vitamin B12 deficiency. Why would B12 deficiency cause large cells? It should be smaller, shouldn't it? Like, what I mean by it should be smaller, well, if you can't fill it full of hemoglobin, then the cell's going to get smaller, and that's true. If you have a condition where you can't fill a cell with hemoglobin, like with iron deficiency anemia, or other types of it, like thalassemia, you don't make enough hemoglobin to make the cell big, so it gets small. You'd think, well, the same thing would happen with B12, but in B12 you also don't make the protein for cell division, so the cells pop into larger cells. So nope, DJ was not wrong again. Wait, DJ's never wrong. Sounds good to me. No, B12 equals no methionine. Can't make the proteins for cell division, so the cells pop into bigger cells. I like C. What does this person have? Microcytic? Yeah, I like that because look at this little guy. This is kind of small. Oh, this one's really small. This guy's kind of small. This guy's really small. Macrocytic, look how huge this guy is. He even has a nucleus in there. This guy's huge. This guy's huge. Some of these other ones look like they have nuclei. What the heck is that in there? Oh, I should have hid something in this image. Oh, smiley face or alien. You name it, it has them all. This is actually a case of a malignancy where you're making too many red blood cells. And so you're making them all shapes and sizes. Those are the anemias. Leukocytes. Leukocytes. Next, we turn to leukocytes. Leukocytes make up about 1% of blood volume. That's far less than red blood cells, obviously. 99.9 and a little less than 1%. While red blood cells stay in blood vessels, white blood cells are free to move. They can break out of blood vessels and move around. Leukocytosis is the term for high white blood cell counts. You don't need to memorize that number specifically. White blood cell counts increase when there's an infection. In fact, your body will upregulate specific cells. So if you have a parasite, you'll upregulate eosinophils. I'm going to be redundant. If you have a bacterial infection, neutrophils, chronic infection, monocytes, lymphocytes, you're going to have a virus probably, and basophils are allergies. The other thing that can cause an upregulation or leukocytosis is malignancy leukemia. We've seen this figure before. We're going to break it up though first. We'll first divide up the blood cells into granulocytes and agranulocytes. So granulocytes have granules in their cytosol, so you can see little granules. Here they're really bright, here they're bright. Agranulocytes have more of a smooth cytosol. There's not a bunch of punctate, that's a fun word, a bunch of blotches of granules. If you're wondering, I slammed a bunch of Red Bulls before I did this lecture, like 4.5. The key feature of a granulocyte is obviously the cytoplasmic granules, but they also share some other features, like they have multiple lobes in their nuclei, so I often mispronounce neutrophils as neutrophils, because they usually have 3 to 4 nuclei. What the granulocytes do is they all are phagocytic, which means they engulf pathogens and debris. Though they all share these granules, and each granulocyte does phagocytosis, they kind of have different fights. Eosinophils, they're generally on parasites and inflammation, so if you don't cook your pork, you can get a parasite called trichinosis, and that's going to cause an elevation in eosinophils called eosinophilia. Basophils stimulate inflammation. Agranulocytes are monocytes and lymphocytes. So again, they lack those cytoplasmic granules. These cells are dominated by a really large nucleus and really little cytosol. So a lymphocyte is almost all nucleus. For the most part, bacteria are killed by the first and second line of defense. So the main pathogen that makes it to the third line of defense, where you have those T cells and B lymphocytes, those are going to be viruses. So an increase in lymphocytes generally indicates the presence of a viral infection. Monocytes generally indicate a chronic infection. These guys kind of roam all over the place, but they're also antigen-presenting cells. Which property do white blood cells have in common? They're not all granulocytes. I suppose they are all nucleated and have a protective function. They're not all phagocytes because a lymphocyte is not a phagocyte, and clearly you need to take a nap if you think that white blood cells transport oxygen. Sorry. Production of red blood cells is called erythropoiesis. Production of white blood cells is called leukopoiesis. The only reason I'm showing such a complex figure is to point out that the production of white blood cells is so much more complex than the production of red blood cells. When it comes to red blood cells, it's do I have enough oxygen? Nope. Well, make more. Do I have enough oxygen? Yep. Well, I'm good. Again, this comes back to the fact that the body can upregulate specific white blood cells based on the available threads. So for those going into the pharmacy, I throw this in here too because this is from a pharmaceutical company and it's showing different, like, well, if you want to stimulate the neutrophil, you got to have a tissue factor, or maybe you have an IL-4, an interleukin-4. If you want to stimulate the basophil or the eosinophil, where's the natural killer cell, my favorite cell? I guess it's not on here. If you want to stimulate the B cell. So what they're essentially saying is these are the interleukins that we would like to replicate in the pharmaceutical industry if we wanted to upregulate a particular cell to fight a particular pathogen. I don't think we need to go into a whole lot more detail than that, even for the pharmacist or the non-pharmacist. I don't think we need to talk about colony stimulating factors or interleukins in any more detail. I just wanted to point out that when you have a particular pathogen, you'll upregulate a particular type of white blood cell. Well, we talked about 5 different white blood cells. Those are just the mature cells. There's several white blood cells in the path to develop these mature white blood cells. So the mature cells are down here, but there's many other cells in the path. The reason to appreciate this is there's multiple types of cancer associated with excessive cell division of these immature white blood cells. We'll talk about those next when we move on to leukemia. The first thing to understand in the production of white blood cells is that there's 2 major pathways. So there's the lymphoid pathway and then there's the myeloid pathway. All formed elements begin with a cell called a hemocytoblast up here. So notice the hemocytoblast is up here, B lymphocytes, T lymphocytes, natural killer cells, platelet cells over here, red blood cells, all the major white blood cells. Start with the hemocytoblast. If a cell is going to become a myeloid stem cell, it's going to go through and become either a platelet, erythrocyte, basophil, neutrophil, eosinophil, or a monocyte. If a cell is going to become a lymphoid stem cell, that's kind of nice because those are going to be lymphocytes, and natural killer cells are a type of lymphocyte. Looking down here, myelocytic leukemias involve myeloblasts, lymphocytic leukemias involve lymphocytes. Another division is between mature cells or immature cells. So if the leukemia is of an immature cell, the mature cells are not going to be produced, and so the immune system is compromised. If this condition is not fixed soon, systems will develop quickly, and it may be lethal, so the condition is considered acute. There's a quick onset of problems. If there's an overproduction of mature cells, there will be consequences to that, and they could be lethal, but they're usually less lethal. There may be too many white blood cells. That leads to inflammation, or resources might be taken away from red blood cell production, leading to anemia. The symptoms and consequences do not develop as quickly and may be long-term, so the condition is chronic. So let's look at those 2 things together. Acute myelogenous leukemia is the cancer of immature cells in the myeloid stem cell line. Chronic myelogenous leukemia is cancer of the mature cells in the myeloid stem cell line. Acute lymphocytic leukemia is cancer of the immature cells in the lymphoid stem line. Chronic lymphocytic leukemia is cancer of the mature cells in the lymphoid cell line. We're not going to go into a whole lot of detail. Again, if that's one of those things that's interesting to you, look it up on Wikipedia because it's really interesting. There are pretty big differences between the types of leukemia in terms of survivability and the likelihood that it's found in adults versus juveniles, and even in men versus women. I bring this up simply because it illustrates how much we just don't understand about the body. It's puzzling that types of leukemia strike men 80% of the time or affect the youth and elderly, but not in the middle age. Switching over to elevations of white blood cells, boy, this is the 3rd time, sorry, but redundancy is good. On the test in lecture, you'll be given a picture of a white blood cell and need to identify the white blood cell and state what an elevation of that cell would indicate. You don't need to go on and on. You can be very brief. An elevation in neutrophils indicates a bacterial infection. Elevation of lymphocytes usually indicates a viral infection. Elevation of monocytes, chronic inflammation, chronic infection. Eosinophils, allergies and parasites. And basophils are an inflammatory response. In lab, you should be able to identify those white blood cells under a microscope, maybe not basophil, but certainly all the other ones, and then again state what an elevation in that type of cell would indicate. So memorize these good for this test in lecture because the lab test is not till the end of the semester. AMP instructor has an increase in this type of cell. What's he have? That looks like a... Some people call them alien eyes, or earmuffs begin with E, and so eosinophils begin with E. I like eosinophil. This AMP instructor didn't cook his pork. He's got worms. AMP instructor has an increase in this type of cell. What's he have? Mispronounce it neutrophil, as in 3 to 4 nuclei. Tricycle has 3 wheels. A neutrophil has 3 nuclei lobes. This guy is suffering from a bacterial infection because neutrophils fight bacteria. AMP instructor has an increase in this type of cell. What's he have? I don't see any granules. It's about the size of a red blood cell. That's a lymphocyte. AMP instructor has mono from Epstein-Barr virus, which would be elevated. That's a virus. I'm going to go with D. Basophil, monocyte, neutrophil, lymphocyte, eosinophil, if you were quizzing yourself. Lymphocytes are elevated in mono, which are granulocytes, basophil, neutrophil, eosinophil. Ace your test. Platelets, the last of the formed elements. Platelets are created as megakaryocytes, give off fragments. So megakaryocytes allow fragments to peel off, and then those become platelets. Platelets will still have constituents of cells like ribosomes and mitochondria, and they still need to make signaling molecules because they are still active cells. They are capable of reacting. They'll signal they have found collagen, and the only place to find collagen is if there's a wound and collagen leaks in from outside the blood vessel. This signal will attract other platelets to migrate towards the wound and help plug the opening. There's many factors, including serotonin and ATP, that are used by platelets to signal other platelets. I'm always stunned by things like serotonin, which we would generally associate with a mood and a sleep neurotransmitter, but here it is, used by platelets to say, hey, I've got an opening. Come over here and help me. Otherwise, I'll be in a bad mood. Oh, that's a horrible joke. Megakaryocytes and platelets begin, as all formed elements did, as hemocytoblasts. Mastery thinking, look at more pathologies. Look at pathologies for erythrocytes, leukocytes, platelets. Just look up leukocytes, platelets, and erythrocytes. You'll go a long ways with that on Wikipedia. Oh boy, I guess I haven't done this one yet, so I should have moved this one up, but consider the primary danger and disseminated intravascular coagulation. We'll talk about that one. Got ahead of myself. Hemostasis. Note that. Hemostasis. Your brain probably just said to yourself, homeostasis, but this is hemostasis. So to finish up blood, we need to talk about hemostasis or blood clotting. Hemo as in blood, stay. Hemostasis involves a long and complex series of steps. These steps can be broken down most basically into 3 steps. Constriction of a cut blood vessel, plugging the opening with a platelet, and binding the platelets together by blood clotting. There's 2 additional steps that we will cover briefly at the end, and that's where you're going to dry out the clot and then retract the clot to heal it. But we're going to mainly just focus on the 3 steps that are indicated here. So constriction, vascular spasms, platelet plug formation, and coagulation. When a blood vessel is cut, the smooth muscle in the tunica media will contract to constrict the vessel. This will lessen the amount of blood flowing in the area of the cuts. Interestingly, one of the theories of preeclampsia, where blood pressure rises considerably in a pregnancy, we're talking up to 200 over 220 over 140, really high, is that tears in the vessels in the placenta release a chemical to cause blood vessel constriction. So when they're tore, they release a chemical that causes constriction. Since a great deal is released, it causes systemic vasoconstriction, which raises blood pressure. One of the significant consequences is that a great deal of protein is lost in the urine. This protein is necessary for the health of the mother. You thought I wasn't going to say it. The urinary system is the most difficult system in AP2. Also, recall that protein is necessary to make albumin by the liver, and albumin is necessary to pull fluid back into capillaries. So consider for a moment some of the additional consequences of that. Blood pressure is going to drop. Edema will result from both a loss in protein and the increased blood pressure. It's not a good thing. Preeclampsia is not a good thing. After vessel constriction, a platelet plug begins to form. When there's a cut, collagen, which is normally found in the tissue, will leak into the blood vessel. Collagen is the primary signal that causes platelets to say, hey, let's get together here. Platelets that find collagen will then release serotonin and ADP to signal other platelets to assist in the clumping. Here's just another closer look at that step of platelet plug formation. The next step is the most complex step, coagulation. In simple terms, the platelets in the platelet plug are roped together. They're tied down to make the clot more stable. So there's red blood cells in here, and there's this fibrin rope. So the rope is made of a protein called fibrin. Fibrin is made of small proteins called fibrinogen, which I like. Gen means generate, so fibrinogen generates fibrin. The signal for the small proteins in fibrinogen to come together into fibrin is stimulated by a signal called thrombin. Yeah, it's going to be like that for a couple of steps here. There are three main pathways involved in making the thrombin that signals fibrinogen to come together into fibrin. I had to say that 25 times before I got that right. If we back up one more step, oh no, thrombin is activated by something called prothrombin. They're all down here. So fibrin is made from fibrinogen. Thrombin signals that. How we get thrombin is from prothrombin. Sometimes pro means before. If we back up one more step, I promise, this is the last step we're going to really back up and be specific about. That's where we get something called factor 10. Sometimes people call it factor X, but the X is actually the Roman numeral 10. There are two pathways to get us this factor 10. There's something called the intrinsic pathway, and there's something called the extrinsic pathway. So fortunately, we won't have to back up any more than that, and I don't really expect you to know more than fibrin, and that the extrinsic pathway gets us there, and the intrinsic pathway gets us there. You'll see that you might want to memorize these things, because things like heparin and coumadin and vitamin K affect these pathways too. So just to iterate, this down here, prothrombin, thrombin, fibrinogen, fibrin, then make the clot, make the rope, is called the common pathway. There are two ways to get to the common pathway. I think about the extrinsic pathway as being a pathway where there is an external signal to tell the blood to clot. This signal is tissue damage. I think about the extrinsic pathway as being a pathway where there's an external signal to tell the blood to clot. The signal is tissue factor, which is released when tissue is damaged. So the purpose of the extrinsic pathway is to get blood to clot quickly when there's a definite signal that blood needs to clot. But you want blood to clot even if it's moved away from where the damaged tissue is. Say it's moved away from that tissue factor, you still want it to clot, but you don't really want it to clot real easily on its own, otherwise it's going to clot in blood vessels. So intrinsic pathway means it's within the blood, it's intrinsic to the blood to clot if it's not flowing. It's slower, but it's going to happen. An example I used to think about this is when you cut yourself shaving, you'll often put a small piece of tissue on the cut. This keeps the blood close to the site where the tissue is damaged, and so the clot will form faster because the blood is being kept next to where the tissue is damaged in tissue factor. But if you let a drop of blood fall away from the body, it's still going to clot. It's just going to clot slower. Think about this too often in terms of our tissue specimens. Often the heart specimens that we have a huge blood clot in the middle of them, or you'll often find blood clots in the cadavers. That's because of the intrinsic ability of blood to clot. So to review, extrinsic is faster, occurs when there's an external signal to clot. Intrinsic is slower, but blood that's not flowing will clot, so it doesn't continue to move around the body if there's internal bleeding. Another reason to know the different pathways is that different pathologies and drugs affect the different pathways differently. We'll get to these specifics real shortly. Again, I mentioned before that technically there are two more steps in clotting: clot retraction, where the clot hardens because it dries out, and then clot removal to repair the wound. Final step in the clot formation is the release of chemicals by platelets. It's not a real well-written question. It's not my question. I'll blame it on someone else. But I would say it's A. Fibrinogen to fibrin is the last step. As long as we're talking about clotting, another reason to understand clotting is that when clotting occurs in a vessel, it's called a thrombus. If a thrombus is in the heart, as often happens when the heart goes into arrest, it's called a coronary thrombosis. When a thrombus breaks loose, it's called an embolus. If the embolus forms in the veins, the first capillary bed it will likely pass through is the lungs. If the embolus blocks blood flow in the lungs, this is a pulmonary embolism. If the embolus continues through the lungs, but is stuck in the blood vessels in the brain later on, this would be a cerebral embolus or a stroke. A common cause of an embolus is a lack of blood flow in the veins in the leg. Blood flow will decrease if you sit for too long because you don't have the skeletal pump pushing blood through your veins. so you can get clot formation. Then when you stand up, as if you've been in an airplane chair for a long, long time, the clot will be released. It'll turn from a thrombus to an embolus and hopefully get caught in your lungs, so you get a pulmonary embolism. So this is why you want to get up and move around the cabin once in a while if you're on a long flight. This slide types out the drugs that affect blood clotting, but let's take a look at the next slide where we can do it a little bit more visually. Here's where we get to the specifics of drugs and genetic factors affecting blood clotting. So Coumadin, over here, it's also known as warfarin. Old name was warfarin. Slows the extrinsic pathway. Heparin inhibits the conversion of prothrombin to thrombin. Vitamin K stimulates multiple factors in the common pathway, specifically factor 10 though. Aspirin prevents platelets from clumping in the first place. One thing not on this figure is hemophilias, where there's a genetic mutation in blood clotting affecting the intrinsic pathway. So you don't need to memorize these specific types of hemophilia, but in hemophilia, there's a general lack of ability to clot blood that may lead to excessive bleeding and death without injecting clotting factors when bleeding is occurring. Last thing I kind of mentioned before because I got ahead of myself is, in addition to bleeding pathologies caused by mutations in clotting factors, alterations in platelets can also lead to problems with breathing. So in disseminated intravascular coagulation, platelets begin to clump erroneously. Clearly in those areas where the platelets are clumping, circulation is going to be reduced. So notice the paleness of the fingers. It looks more pink out here and more white in here because of the loss of circulation. Think about it too, that you don't have an infinite supply of platelets. An additional problem is that the platelets are kind of used up, so unchecked bleeding may occur elsewhere. DIC is most common in pregnancy or septicemia. Sometimes blood transfusion errors too, because the platelets and the blood starts to clump and use everything up. Thrombocytopenia is when platelets are deficient. Patients show, take a guess at how you pronounce that word. It's a fun word to say. Petechia, purple blotches on the skin due to spontaneous widespread hemorrhage. Here is where you have to treat with whole blood transfusions so you can get those platelets. I don't know why I didn't put a text here, but bleeding disorders, can't synthesize clotting factors, don't have enough vitamin K, can have not enough vitamin K. Oh, that's a good example. I should have wrote up the text and enhanced this one. Vitamin K is a fat-soluble vitamin. You need the liver to absorb fat-soluble vitamins because you need to make bile that helps you break down fats, and the vitamins are in that fat. So again, liver failure can lead to lack of vitamin K. Lack of vitamin K can lead to bleeding disorders. All right, so last thing then is mastery thinking. So look into various strategies to counter coagulation. Think about if your uncle's been placed on Coumadin. Also, it's kind of cool to look at different strategies to restore hemostasis. Sutures and ties, tourniquets work well, things like that. Anyway, that's blood. Thank you.